Hi, Tanner. It's been about 2 years since we last had a conversation out here, at least. Obviously, we've seen you many more times in the interim in the clinic, but maybe just give us an update on how things have been over the last 2 years and sort of where you're at now.
We did a surgery a little less than 2 years ago. Got a little bit of it out of my right shoulder, right armpit area. And then after that, we did the BRAF drugs for 6 months. And then came off of those and been clean since then. Had a clean brain MRI today and then have a PET scan next month. But overall, can't complain. Everything's been fine.
So your tumor had a specific mutation that allowed us to use a different medication than we used initially. That's right. Remember, we used the immune therapy drugs initially and got a pretty good response, right, Tim?
We had a run of about a few years just on immunotherapy maintenance.
That's what we're going over today.
Maintenance, yeah, and your recurrence was not widespread, I would say. It's a localized recurrence, but we know that once you have progressive disease on immunotherapy, for you we have a couple options, right? We were using the immunotherapy, but we know you have this mutation called BRAF. And thankfully, we have oral drugs that can target this mutation that drives the proliferation of cells. Even though we got most of the cancer out with the surgery, there was still some left over. We know if we leave it there, it's gonna eventually grow. So because you have this mutation, we put you on the BRAF targeting therapy, and that basically dissolved everything. We sort of anticipate that, but it's always good. We always like to see the reassurance that happens.
How the pills, how you tolerate them?
They were okay. They were not my favorite thing in the world, but in the big picture, I'd say the pills were not as bad as the double drugs at the very beginning. Those had more side effects. The pills made me tired. I was a little winded, but for the most part, life was pretty much normal.
Yeah, I'm actually surprised thinking back that it was only 6 months, because it seemed like it was longer, because I feel like you were not
longer.
Exactly. Yeah, I mean, Tanner's a stoic guy, I think, and you just push right through it. But I think
no choice.
The pills, but the pills do have their side effects, but they do allow you to, continue your normal life. You had some fatigue.
Yeah.
I think you were having some nausea at one point.
At the very beginning, it made me feel a little nauseous, but then the fatigue and just I would get dizzy a little bit on them if I would do anything too quickly. Right. Or stand up, like if I was bent over playing with the kids, standing up really fast would make me dizzy. But once you got used to what you can and can't do on it, I feel like a bunch of it's just managing what you can and can't do.
Did it stop you from going to Disneyland any though?
Nope. Nope, we were there. It's been a few weeks since I've been there. The kids were there on Monday, but no, we did Disneyland. We haven't stopped really doing anything.
And I think that's been what I've always been most impressed about you, is that you really haven't stopped for much of anything.
No,
through all of this. Yeah.
From the very beginning, from meeting Fisher first, right out of the gate, and then I remember the night he called, he's like, all right, pack a bag, you might be staying. And we came and met with him and Barkhoudarian and O'Day at the time.
Right.
And decided how we're gonna go at it. And then, I had a brain surgery it was a Thursday, I went home Friday. We went to a neighborhood party on Saturday. I went back to work on Monday. I couldn't drive for 2 weeks because of the seizure drugs. But other than that, just keep going. Slowing down is not gonna make it any better or worse.
What do you think's been one of the takeaways from your treatment here at St. John's?
Overall takeaway, just deal with the best people you possibly can. You guys have worked together to make sure, any side effects or symptoms of anything going on, so I say, let's tweak this or adjust it, and I don't know, just find the people that'll take care of you and trust them and go from there. It's worked this far.
You really have had the whole team with you. You've had Barkhoudarian, you've had the neuro-onc people that see you, Dr. Fischer, Christine when she was here.
yeah.
I know Christine. She was like
one.
the glue. She was like the glue for everybody. Right?
But I remember arguing with her very early on, like, she was the one that was always telling me when I was really feeling bad, like, you need to take the steroids. It's like, no, I don't want to take the steroids because I had in my head that it was going to slow down the treatment, and I was convinced I could just muscle through it.
Yeah.
And she's like, no, like, you just got to listen. And once I finally did listen to her, it was better.
Yeah,
but
she had a special gift of being able to tell people what they needed to do without being, like overly aggressive or harsh or paternalistic about it.
Yeah. Like, why are you asking if you're not going to listen?
That's an important part of having a sort of the team approach, is that everybody has their strengths.
Yeah.
Christine, as a nurse practitioner, dealt with a little bit of a different angle of how we get things done, and I think we all have our strengths, and our focus really in treating anybody here is to really put the patient at the center, and then use all the resources that we have to provide the best care.
Yeah.
So far, you're a good example of that.
Yeah, you guys do. It's all, it's all focused around us.
What's the future look like for him, Tim?
Well, now that we've got him off the pill therapy, he's got a lot of his energy back. He's basically back to baseline.
Yeah.
Restarted the immunotherapy with the hopes that we're just going to keep the disease at bay for as long as possible. I mean, I think there's always that chance that we've done enough to, I think, eradicate everything and be able to keep it away for the long term with immunotherapy. But that only time will tell. I think it's very possible that we're going to be cycling back onto the pills if we need to, if there's some cells
if
that
anything
escape.
ever came back.
If some rogue cells were growing and try to manage it that way. It's been sort of ad lib at this point. We talked about him being off any kind of established algorithm at this point.
But we never know what's coming in the future either.
Yeah,
Even since
exactly.
you've started treatment.
Yeah.
There's new treatments that are coming on. We're still doing clinical trials to find new targets and new combinations.
Yeah.
And so the goal is that you never need it.
That's the goal, right?
Another part of that, but there's always options, which, probably when Dr. Kristedja, when you started taking care of melanoma patients, the options were not as...
The dark ages, yeah. I mean, when I started, it was just kind of the dawn of the immunotherapy age, and in fact, the whole immunotherapy movement had died for a bit. I remember doing my fellowship interviews. This was 2008 or so, and I was at a very prominent academic institution with a well-known breast cancer academician who asked me about, what do you think of immunotherapy? I see you work with Steve O'Day, and they knew each other because they had trained together at Farber. And he was kind of looking off into the distance, and he said, I think it's dead. This guy that I was interviewing with, they had known each other, and it was the IL-2 thing and interferon had kind of run its course and had, it was known for producing good responses, durable responses, but only in a small percentage of people, like 10 to 15%.
Whoever could sustain it.
Correct. So, but there was still a little kernel of hope that it was working for some people. And I think for someone like Dr. O'Day, he kind of never let go of that evidence that a small number of people were benefiting long term, and so there must be some other way. So this was, and literally 2 or 3 years later was the big plenary session that Dr. O'Day actually gave at the annual meeting about Yervoy, ipilimumab, which is one of the drugs.
That's what I was on at the beginning.
And that started off this whole new wave of harnessing the immune system.
That's what did the heavy lifting of mine, isn't it? Or is it the combo?
I mean, it was
of
probably
together?
the combo. It was probably the combo. The drugs, they work in slightly different ways. They have different side effects, and certainly we think there's some, there's some magic with the two together. You don't necessarily realize giving one at a time. I still think there's so much to learn, and so much we're on the cusp of knowing about how the immune system works to kill cancer, and I think, the future's still wide open for all of that. Most melanomas that are diagnosed in the world are thin lesions on the skin that get cut off and then never come back.
And that's
right?
it?
Yeah, that's it. 90%.
It's a
maybe.
little bit more delicate than just cutting.
Oh,
it.
right.
I mean, don't underestimate
Right.
what I do. I mean,
it's
very intricate,
That's true, yeah.
intricate surgery
Yeah,
with
I
expertise.
don't-
That
correct.
no, but you're right.
Don't mean to downplay, yeah.
Most melanomas just need a surgeon, and
Yeah.
and if it hasn't spread to lymph nodes, then usually you're done. There's always a small risk of it coming back, but that risk is low.
Yeah.
What's the timeline? Because I had that spot for years and it had it checked, and we never got into it. Like, if that would have been properly, let's say, diagnosed and removed 10 years ago when I first had it, would that have been the end of it? Or would it have gone, like, without that host, would it have gone to the lymph nodes?
The real answer, I think, is we don't know.
Okay.
But I think the great likelihood is that would have been it. And
That would have been it.
That would have been
So
it.
if the guy originally would have got it,
Correct.
we wouldn't
yeah.
be sitting here doing this.
I mean, that's the general principle of cancer. Once cancer has left its home where it started and gone into the lymph nodes, and particularly with someone like you, where it's gone, to other parts of the body, presumably having traveled through the bloodstream, we know that this is now what we call metastatic disease. When we're dealing with metastatic disease, particularly for melanoma, the intensity of therapy has to be increased.
Because it's pretty aggressive, isn't it?
Well, aggressive or has the potential to leave and show up
Gotcha.
somewhere else later. I think with other cancers, we keep patients on therapy only as long as the body tolerates. And often there's no real true hope that the cancer will be gone forever. But in melanoma, because of its association with the immune system and its sensitivity to perturbations of the immune system, we can actually see cures with patients who have metastatic disease. There was a time when I started, the number that would be quoted would be less than 2% of patients would survive beyond 5 years. Yeah.
And that was a conversation Fisher and I had. I remember meeting him the first day here when he took it off my collarbone, and I was like, is this gonna kill me? He's like, no, you'll be fine. Like, you've got plenty of time. And, it's scary stuff. But I remember reading those stats.
It all depends on how you had a good response. So fortunately, we do get lots and lots of successes, but it's not everybody.
Yeah.
And the only thing I was going to add to the timing of it all is, with any cancer, the earlier you find it, the better. There's no cancer that doesn't benefit from early detection. And so sort of the plug, I guess, would be, make sure everybody gets checked.
Well, how many times have I asked you for recommendations on where to send friends and all that? And my sister had a hard time getting in with one. I texted him, like, hey, he's like, they'll call her tomorrow. And sure enough, she got
There you go.
an appointment right away.
Yeah,
But
it's important, and especially, with family members of people who've had melanoma. It's likely not, a genetic, it's not a mutation that's causing the gene, the melanoma, but it's the things like skin tone and all those things that you share with your siblings and you give onto your kids, that gotta keep them covered up and make sure that you're getting checked.
as fun as you guys are, I don't want to introduce a ton of people to you.
Best to meet
hopefully.
outside of the clinic.
Yeah.
Exactly. Disneyland.
There you go. He'd love to go.